Hi, I'm Nandi. I'm a licensed midwife, a trained doula, and a mother of 3, and I'm based in Sweden. Welcome to my channel. In this video, I'm going to talk about common hospital routines during a C-section. I already made a video with common hospital routines in Sweden, so check that one out. And this is more specific for a C-section. Please note that all hospitals have their own routines, and I'm trying to give kind of like a general picture. If you want more detailed information, because you maybe know that you're having a planned C-section, please contact the hospital where you're going to give birth at, so you can find out more. But this is just to give you kind of like a general idea. There are 3 types of C-sections. The first one is a planned C-section. So a planned C-section is a C-section where you get a time, a date, a schedule for the surgery. You will know it beforehand, you will be prepped, everything will be ready. And the reason for this varies, but I would say in general it's usually some kind of medical reason. It could be that the placenta is in a position that isn't conducive with birth. Your baby is transverse, so it's laying like this, can't come out vaginally. Unfortunately, in some places they still only recommend C-sections for breech, so bottom down babies, but it's getting more and more common to measure the pelvis and try for a vaginal birth if the couple is comfortable with that. Another reason for a planned cesarean may also be that you have fear of giving birth vaginally, and then it's a doctor that approves that you can have a C-section instead of opting for a vaginal birth. I don't know how common that is, but it does happen. In general terms also, if you have had 2 previous C-sections, most hospitals will not approve a vaginal birth after that. You will go directly to scheduling a C-section. I've heard of very few cases where women have given birth vaginally after 2 C-sections, but I would say most doctors will probably not approve that. And the reason for that is that where the scar is in the uterus, the scar tissue has a greater risk of tearing when the uterus is contracting. And that of course puts both baby and the person giving birth at risk. So that's why it's not recommended for most people to do that. Another type of C-section is an unplanned C-section. It's also called emergency C-section in Swedish, akut kejsarsnitt. And this, how quickly this happens varies. But usually it has to do with the labor not progressing, the baby is not handling labor well anymore, the person giving birth has given up, is out of energy, and the labor, there's still very, very many hours to go. Sometimes it has to do with the fetal position, so the position the baby is in. Usually during the emergency, or if we like separate the emergency and like the super emergency, akut kejsarsnitt. So the emergency kejsarsnitt, akut kejsarsnitt, you are usually awake, you get a spinal anesthesia, and the time from when it's decided to the baby is supposed to be out varies depending on the situation, how rushed it is. Sometimes it's just like, okay, we want to do a C-section within an hour. Other times it's like, we want to do a C-section now. So that varies. But I would say in general, that C-section you stay awake. The third type of C-section is an emergency C-section, but like a more emergency C-section, urakut kejsarsnitt. Urakut kejsarsnitt, you're generally put to sleep. There is usually like, I think it's 15 minutes from when it's decided to the baby should be out. It's a life or death situation, or like a life or serious injury situation. So it's usually when there is a risk for the person giving birth. or the risk, like an emergency risk, of course, for the person giving birth or the baby. It can also be something like all of a sudden the placenta has detached from the uterine wall and the bleeding, and that also of course makes it so baby is not getting oxygen through the blood, and that's an emergency. It needs to happen fast. I will now focus on the type of C-section where you are awake. So in most cases when you are awake, you can have a support person with you in the surgery. That person will sit next to you, next to your head, and there will be like a sheet. It's not cloth, but like a surgery sheet from about under your breast and downwards. So the person that's sitting there will not be able to see the actual surgery. The surgery will be performed in an operating room, and there will be quite a lot of people in the room. The lights will be bright, and it's a sterile environment, of course, to keep bacteria from going into the operating wound. So you'll have an anesthesiologist, you'll have anesthetic nurse. What is that called in English? A nurse that works with the anesthesiologist. You'll have an OR nurse, maybe an OR assistant nurse. You will have the obstetrician, maybe 2 obstetricians is what I'm used to when I've attended cesareans. The midwife will be there, and the assistant nurse. So there's a lot of people in the room, and everybody has their specific job to do, and everybody in the team is really important for making the surgery run smoothly. So in this situation where you're awake, you will in general have, if you have an epidural, I do this because the line from an epidural is usually attached here. Sometimes my body language doesn't make sense to anybody but me. So if you already have an epidural, they might just top up that epidural with the medication that you need to be numb from the waist down. If you do not have an epidural, they will put in like a spinal anesthesia, which is more or less the same. It goes through your back, and it makes you feel, it cuts off the sensation from about your chest down, basically. You will also have like a lot of drips going in, and they will give you different medications. You might have an oxygen mask if you need that. You're connected to a computer so they can see your vital signs all the time. So it's very much of a hospital setting, more like traditionally how people think of a hospital than what we're used to in like a birth setting, which is maybe more less people, and like to enhance physiology the light should be dimmed and so on. So it's quite a different, I wouldn't say a little, it is a different experience than having a vaginal birth, of course. So the surgery will begin when the person giving birth is completely numb from the waist down. They check that, and then they will commence. What happens is they use a scalpel. Is that the same word in English? They cut into the layers of the skin, the fat tissue, the muscles, the muscle of the uterus, and so on. So there's different layers that they cut into. There might be shaking of your body and pressure and uncomfortable, but it should not be painful. If it's painful, then they need to top up your medications. It's really important, if you feel any sensation of pain, to let your anesthesiologist, if you feel any type of pain, it's really important to let the staff know so they can give you something for that pain. My job as a midwife during a C-section is to stand next to the obstetrician and be prepared to get the baby. So what the obstetrician does, and when all the layers are cut and they have opened the uterus, they will reach down and get the baby out. And place it, in my experience, I don't know if it's the same everywhere, place it on the person who's giving birth's legs, and I will wipe off kind of the water and the blood, make sure the baby's breathing is fine. In my experience is that they will perform some kind of delayed cord clamping, so they will not cut the cord right away. They will generally wait. We always have a pediatrician standing by in the next room if the baby isn't breathing or is having trouble breathing, so we can give the baby help right away. And then in that situation, they might just wait to cut the cord for 1 minute, because you have 1 minute for the baby to kind of react and start crying and breathing and adapting to the life outside the womb. If the baby needs any type of help from the pediatrician, you might have a neonatal team, so it might be a pediatrician, a neonatal nurse, or a pediatric nurse, depending on what the situation is in your hospital. Where I used to work, it was a pediatrician, and me, the midwife, and assistant nurse from the delivery ward were the ones that would care for the baby after birth. Once the baby is fine, so we're going to go with the idea of babies doing fine. Here it might vary from hospital to hospital. Where I used to work, we would, if the baby is doing fine, I don't need a pediatrician to look at the baby. I would place the baby. I'll go directly from behind the sheet where the surgery is being born, and place the baby skin to skin at the skin to skin of the person who has given birth. This is useful for many things, of course. Makes the person who's giving birth relax, but also for the baby, skin to skin is so important to adapt to the to being born, to stay warm. Their heart rate goes down. They maybe can even start breastfeeding there on the surgery table. So it's really, really important. You can do a lot of things and keep the baby skin to skin. You can cut them by umbilical cord, because usually during the surgery, when they cut it, it's quite long. So you can offer the partner or the birth companion to cut the cord. The baby is still laying skin to skin. If you want a vitamin K shot for your baby, that can also be given there. But this is very much dependent on what routines the hospital have. So if the hospital do not do skin to skin right away, they might take the baby out, have it checked out from the neonatal team or the pediatrician, and then bring the baby to the person who's giving birth, for sometimes for skin to skin, other times wrapped in a blanket or towel, and you just get to see the baby for a short period of time. This varies. Like I said, it has a lot to do with the hospital routines. We know that it's better to start skin to skin right away. We know that it helps breastfeeding if you can breastfeed right away. But these are not options that are available everywhere, unfortunately. So if this is something that you're really passionate about, and you know that you're having like a planned cesarean, you can find out if these options are available where you're going to give birth, or if you want to include it in your birth preferences, that skin to skin is really important. If there's an opportunity, I would like for baby to breastfeed even during the surgery, and so on. And I think the more things like that get requested by the people having the baby, the more the staff will understand that these things are actually important. So you have you're doing something for yourself, but you're also doing something for other people that are following. If the staff, maybe sometimes the staff hasn't even thought of it. So it's nice to, if it's important to you, just add it or address this as an option. So what happens next varies a lot depending on which hospital you're in. So it might be that the birth companion or the partner and the baby have to leave the surgery room and be somewhere else, in like the postnatal ward possibly, while the surgery is finishing, because the birth itself is quite quick, but the what happens after the birth actually takes a while to stitch everything up and so on. So in that situation, I always recommend for the partner or the birth companion to take off their shirt and have the baby skin to skin. This is to regulate their temperature, make them feel safe, all the benefits of skin to skin. If the person giving birth can't, the next best person is always the other parent or the birth companion, right? So I would not suggest to place the baby like in a crib or on a bed or something. Make sure the baby's undressed, is in only a diaper, maybe a hat, and place them skin to skin. In other places, there might be an option to have 0 separation, so you go directly when the surgery is done to the post-surgery ward, and the partner or the birth companion and the baby can follow along, and the baby can stay skin to skin during this entire time. This is to be if you can choose, this is what you should choose, because there's so many benefits for the person who's giving birth. You heal better, you experience less pain because you have your baby close to you, which boosts your oxytocin, which helps you with the pain. For the baby, there's so many benefits. Skin to skin, they breastfeed quicker, they regulate the temperature quicker, their bowels adapt better, breathing is better, heart rate is better. I can go on and on and on. I'll do a separate video on skin to skin eventually. I have that in the plans. Okay, so those were the routines that I could think of when I sat down to think about the more general routines. If there's anything that you experience when you have a C-section in Sweden, please leave a comment below and share that if I missed something. If you want me to go more in depth on C-sections or something linked to this video, please leave a comment as well. Don't forget to subscribe to my channel and follow me on Instagram if you don't do that already, at Nandi's Insta, and I will see you in the next video. Hej då!